have technical consultation on on indicators on adolescent health. We also have documents that give us guidance on how to conduct research among adolescents, and also recommendation on standard indicators to measure adolescent health. Next slide, please. So now I'll look at more closely at the Kenyan strategies and policies. So we have a newborn child and adolescent health policy, which is the overarching policy that we use to base our adolescent programming in the country. We have the adolescent strategy 2021, which is in draft. We have done the validation for this document and we are about to launch it. We have the school health policy 2018, and we have the school health strategy 2021, which is also in draft, that is about to be launched after a validation meeting. Then we have the National Adolescent Sexual Reproductive Health Policy 2015, which is currently under review. We have our mental health policy, the menstrual health management policy, mental health management strategy, and the national e-health policy. Next slide. We also have various guidelines and action plans that touch on adolescent health. So we have the adolescent health guidelines in draft. We have the school health guidelines that were launched in 2018. We have the guidelines for reopening of schools amid the COVID-19 pandemic. We have guidelines on provision of adolescent and youth-friendly services in Kenya. We have protocols for treatment of substance abuse disorders, though this is not directly targeting adolescents, but it has been used in the programming for adolescents. We have the National Physical Activity Action Plan, and we have the Violence and Injury Prevention Plan of 2018 to 2020. Next. So those are just but a few of the documents that touch on adolescents in the country, but they're the main strategic documents. I'd like to emphasize a little bit about this adolescent health strategy that we are in the process of finalizing, because it's more of an overarching strategy, and its strategic directions are on empowering adolescents to be partners in their own health, leadership and coordination between the national, county, and even regional and global levels, empowering the parents, teachers, and communities to take responsibility towards adolescent health, to give a guidance on adolescent health responsive services, which just give an outline of how these services should be provided to adolescents in the country, but it's actually the individual division disease specific areas that will be doing the implementation. And then we have strengthening systems for data collection, monitoring, evaluation, surveillance, and research. Next slide. So I'll go now into the adolescent data. We'll look at the context, morbidity and mortality. And these are estimates that have been calculated by UNICEF, and the link is there on the previous slide. So just quickly, we can look at the adolescent population globally. There are about 1.2 billion adolescents in the world, which are 16% of the global population. While in Kenya and in the East and Southern African region, we see that adolescents constitutes a slightly larger proportion of the population, almost a quarter of the population. When we look at the adolescent birth rate in the world, it's 40 per 1,000 girls aged 15 to 19 years. But in the East and Southern Africa, this figure almost doubles. So we have about 108 per 100,000 girls giving birth in East and Southern Africa. These are adolescent girls between 15 to 19 years. And in Kenya, we have about 96 per 1,000 girls giving birth who are 15 to 19 years. And when we look at the general adolescent mortality that was calculated from estimates of 2019, among the younger adolescents, the global mortality is 3 per 1,000, but in the regional and Kenyan area, we have 5 per 1,000. And in the morbidity, the mortality, for adolescents 15 to 19 years, these are the older adolescents, we find there's significantly more mortality among this population. The global average being about 5 per 1,000, and in Kenya it's about 6 per 1,000. When we look at the population living below the poverty line, globally it's about 18,000, but when you come to the regional level, it comes to about 38,000, and in Kenya we're at about 36,000. And the population with moderate to severe food insecurity, globally it's about 19%. In Kenya, almost half or more than half of the population has moderate to severe food insecurity. Next slide, please. So this is a bit of a busy slide, but I'll just try to highlight it. These are the top five causes of adolescent mortality deaths globally, in the region, Eastern and Southern African region, and then in the Kenyan region. So globally, we find like non-communicable diseases like mental health conditions, iron deficiency, uh, anemia, and such like cause more mortality than communicable um, diseases. So, and you find like adolescent boys globally, issues like road injury, interpersonal violence, self-harm, drowning, and other unintentional injuries are the leading cause of death. And what is striking is that diarrhea causes significant mortality among all age groups, both globally, regionally, and in Kenya. In the Eastern Southern African region, communicable diseases like HIV, TB, diarrhea, lower respiratory tract infections, parasitic and vector-borne diseases cause more mortality than non-communicable diseases. However, when we look at our Kenyan situation, road injuries are the leading cause of death in adolescent boys. And also, if you look also at road injuries, it's also among the top 5 leading causes of death in both adolescent boys and girls. I also want to highlight the maternal conditions among the girls aged 15 to 19, which is the second leading cause of death in Kenya. So we also see in Kenya, diarrheal diseases causes significant death among this population, in addition to other communicable conditions like TB and HIV. Vector-borne diseases like malaria and helminth infestations are also an important cause of death in this population. Next slide. Next slide, please. So here we are looking at, sorry, please go back. At the years of healthy life lost due to disability, which is a measure of morbidity or sickness among adolescents. And when we look globally, we find like more non-communicable diseases like mental health conditions, iron deficiency, anemia, and skin conditions are a leading cause of sickness. And things like skin conditions and iron deficiency, anemia, they cut across all sexes and age groups. But when we come regionally, we see that HIV and AIDS, tuberculosis, diarrhea, parasitic and vector diseases, lower respiratory tract infections are also a leading cause of sickness. And in Kenya, we see an increase in mental health disorders, which are things like depressive and anxiety disorders. And when you find childhood and behavioral disorders are more prevalent in the younger age group than the older age groups. And other maladies like skin conditions are also among the top causes of sickness in these adolescents. Next slide, please. So when we look at some of the risk factors for this sickness and death in adolescents, we want to look at things like nutrition. And here we can see globally there has been an increase in overweight adolescents and a decrease in adolescents with thinness, with an overall increase in adolescents who are obese. Next slide, please. And in Kenya, when we look at other health risk factors, we find that adolescent boys have more heavy episodic drinking. That's about 12% of them have heavy episodic drinking as compared to 2% of adolescent girls. They also twice as likely to use tobacco. That's at 13% compared to 7% of adolescent girls. And what is a worrying trend is the insufficient physical activity, which is almost 90% in both adolescent boys and adolescent girls. Next slide. So what are the opportunities we have to improve adolescent health and information? As you can see from the previous slides, we have a lot of estimates, and these estimates are actually calculations or modeling that has been done on previous studies and the current disease trends that are reported on a DHIS routinely. And the problem with these estimates is that they give like a rounding off figure. They don't tell us exactly what we need to know about adolescents. When we look at the data that is presented on DHIS, the data is there, yes, but it's not disaggregated as per age group. And this is what we are recommending as an adolescent health program, that any data that is reported and fed into any system or from any project should be disaggregated into male and female 10 to 14, male and female 15 to 19, male and female 20 to 24. Next slide.
Christine, 4 more minutes.
Okay, thank you. So I'll just highlight also something else that we've done as the Division of Adolescent and School Health, and that is to conduct a national adolescent health survey that has given us additional information on adolescent health. And so we don't have to rely so much on the estimates if we can have this survey done routinely every 5 years. So the survey is a comprehensive survey looking at the household, the health facility, and the school. Next slide. Next slide, Ken. So these are the recommendations for mortality reduction. To reduce the causes of death, we have to address diarrheal disease by looking at WASH programs, tuberculosis and HIV prevention and control. And parasitic and vector-borne diseases, we need to invest in school and community-based deworming and malaria prevention and control. Maternal conditions, we need to address teenage pregnancy. And for road injuries, road safety should feature prominently in any program that is geared towards improving adolescent health. Next slide. So for morbidity reduction, we are looking at mental health issues. And from the study that I mentioned earlier, we were looking at adverse childhood experiences and how they contribute to mental health issues in adolescents. So we have this as a key action point that we can use to reduce sickness in adolescents, by addressing those mental health conditions. And also for skin diseases, as we can see, it was cutting across. So we are recommending appropriate dermatology clinics and referrals to dermatological services as a key part of programming addressing adolescent health. Next slide. So that's the end of my presentation. Thank you.
Thank you very much, Dr. Christine. A very comprehensive overview. And she's already begun to highlight some of the things that we'll be talking about with regard to adolescents, particularly like data being an estimate, and with a rounding off, we are not really getting a lot of the detail. But one thing I think that we can take away from that presentation is that we have a lot of policies, we have a lot of guidelines, global and regional and national. And so we do have the opportunity to address this particular concern for adolescents and youth. So now I'd like to invite our second speaker. We will have time for questions at the end, so please hold your questions to that time or put them in the chat. So our second speaker this morning will be the CEC for Nandi County, Honorable Ruth Koech, and she is going to give us a county perspective, which is really important because coming from the national level where Dr. Christine has given us the overview, it's then good to see how is that translating in the counties. We recognize counties have different experiences and different contexts. So I'll kindly ask Ken if you would put up the presentation for Honorable CEC, and then we'll move right to it. And Honorable CEC, just like with Christine, you'll have 15 minutes. So welcome. Is the CEC?
Thank you. Yes, I'm there. Yes. Thank you so much. My name is Ruth Koech. I'm the CEC in charge of health in Nandi County. Allow me to thank the partners and the organizers of this It's definitely an honor to represent Council of Governors and to give a perspective of what's going on in the morbidity and mortality among adolescents and young people in the counties. That's where really where the implementation is done. Next slide, please, Ken. So I will briefly, our objectives have actually been covered in the first presentation on policies and programs addressing adolescent and young people health. And I will also the causes of illnesses and deaths and the recommendations for the same. And also I will be covering the missing links in regards to health data information on adolescents and young adults. And what happens in the counties really amongst this population in Kenya, and what are we doing with the guidelines and the strategic documents, or are we really funding it? Next slide, please. Giving an example of what happens in Nandi County, the adolescents and young adults, which is the age of 10 to 24, is a very important segment of the population. And in Nandi County, it's about 35%. And if you look at that number, that is high. So we are not only looking at adolescent and young adult issues, but what will happen 10, 15 years from now. So really, I think health issues affecting needs a multi-sectoral approach, and the focus should be on all aspects. It should be holistic on preventive, promotive, curative, as well as rehabilitative. The major health problems of early adulthood are largely preventive. Many problems are linked to behaviors and conditions with related outcomes, and few young adults have serious impairment that interferes with their daily functioning. And those with chronic conditions like mental disorders must learn to manage these conditions with increasing community support. In the county experience, we have noticed that this is the highest population for most counties and a reflection of really what is happening in Kenya. And like in our county government, like all the referral hospitals have youth-friendly centers. And I would like to appreciate the partners because they took a lead in making all the comprehensive care centers to be youth-friendly. And not only youth-friendly, but ensuring that the care there is catered to serve them. And I think many counties don't give enough funding or budgeting to adolescent and young adults. I think a lot of focus has been on maternal child issues, which I no doubt say that that is very important too, but majority of the population seeking care then in our counties, based on the percentages of adolescent and young adults, is the majority as we speak. And these, most of them are in primary schools, high school, and tertiary education like colleges. And if we looked at what happened recently with the pandemic, that really exposed us, especially when we noted that this is the time where we had the highest number of teen pregnancies. So really, we have covered in the previous presentation, adolescents and young adult challenges, the causes like substance abuse, the violence, mental health, which is a global problem, because we have seen suicides going up, stabbings in schools, children being violent to teachers, STDs, especially with HIV, where the new infection category right now is amongst this population, the young people. And then also lack of social protection, the hopelessness, the poverty that can affect issues like nutrition that will affect your health. And also unstable families. Do these children have peace? Why is mental illness on the rise? Career dynamics, the pressure versus talent, internet addiction, social issues. What are our children being exposed to? And if you see what is on social media, really, it's a reflection of what is in the minds of our children. Gambling, betting, whether it is the children gambling in the middle of a swamp so that they are not caught, or the ones using games online or in real casinos, that is becoming another problem that will even lead to crime because they don't have an income, but it is a problem that is happening. Gender-based violence, sexual abuse, and also the self-induced abortions, which is also on the high. Nobody likes to talk about that, but that is a problem that is definitely on the top. But in many counties, I would say between the age of 10 to 14, 15 to 19, and 19 to 24, all counties in the affected adolescents and young adults, the issues are very unique to each county. And even within the county, in the sub-counties, different sub-counties will face different challenges, or even in the rural setting versus in the more metropolitan town areas, you will be facing different issues and different priorities based on the area. So really addressing the health issues in the counties should be focused on what is happening in that region and to the adults, young adults and adolescents, whether is it addressing nutritional issues, is it addressing sanitation issues. Each county should prioritize and budget more to support this group that has not received the attention that it needs. Also on the issues of self-inflicted injuries and suicide, and also noting from what has been happening in our communities, we've been seeing it in the news, you will see less tolerance to hard life or even rejection. That tells you we're not doing much. There's a big gap on mental health, especially when you see a lot of substance abuse, the children are saying wellness and counseling that they need, are we addressing? So really, I'm sorry, I should have said next slide. Okay, next slide, please. Next one, please. And the next one. The next slide, please. The next one, please. Looking at this slide, if we are to address the gaps and reduce the complications in the unique counties and the sub-counties, if you look at what is happening in Nandi County, like the top being upper respiratory tract infections, the bottom being typhoid, but just looking at it at a glance versus the national presentation, I think we should focus more on the preventive aspect because that is a cheaper way to take care of health issues. Are we looking at pesticides in our environment? Are we looking at vaping with children doing drugs? Are we looking at a lot of smoke in the rural areas with kitchens with very minimal ventilation? If you look at diarrhea and typhoid and urinary tract infection, that stands out. Are we dealing with sanitation gaps or education? Or if you look at the dental disorders, which is about number 8 in Nandi County that doesn't reflect nationally, does that tell us something about our health system? Is there access to oral wellness? Is there a gap on oral hygiene, of which if we don't take care of that, we've known that dental issues will eventually have an impact on cardiac issues. So really we must personalize for every county based on the unique needs in each county. Next slide, please. On the notable gaps, I would say there is lack of accurate data on adolescent and young adults specific health issues. And as we saw, what we get from the DHIS really lumps everything and doesn't totally break it down. And we know quality data. If we have quality data, evidence-based solutions is what we need. We need policies and guidelines from the data, or we could even be having this data like from other sectors. All we need to do is sit together and work together to make the solutions so that if we have a better reflection like on mental health, on the issues to do with the self-induced abortion, substance abuse, or the suicides, we can do a better job on that. On the balance between religious, cultural beliefs and emerging global health concerns in this population group. What are we doing about family planning, about sex? Are we talking, do we still focus on abstinence, yet we know that we have children that are sexually active under the age of 10, or the transition periods for this young group. After Form 4 to tertiary education, what happens to them? Adverse childhood experiences like post-traumatic stress. What happened in 1992 post-election violence or 2007? Did we talk to these children? Because when you start seeing violence in schools, fires in schools, And globally, where you find children going to schools with guns, what does that tell you about the gaps on mental health? Do we have a budget that focuses on this big population, or are we focusing too much on other areas? So we must really ensure that the preventive, promotive, and rehabilitative health should be looked at. On the issues to do with human resource, do we have enough pediatricians? Like in my county, where the population of this age group is about 300,000, and you have less than 3 pediatricians, that is not enough. Or on the other sectors, like the counselors, the nurses, do we give them the capacity building for them to provide these services? Because like for the young adults and adolescents, we need healthcare providers that are open-minded, that will not judge them, will maintain their privacy. Are we including the peer mentors? Because that's the only way we'll be successful taking care of them. And also the failure to monitor behavior change among this group is another issue that we must look into. On key players and other responsibilities. Next slide, please. Health needs, as I will repeat it again, needs a multisectoral approach, because a lot of the health issues are caused from psychosocial economic issues, poverty, family issues, behavior, and the environment. So for administration and government, enforcing strictly the laws on sexual violence, gender-based violence, is establishing social protection should be an agenda so that we can reduce the teenage pregnancies. What do we do with statutory reps to deter it so that we can have less teenage pregnancies? The civil society, advocacy for friendly laws and programs so that there is less neglect, less exploitation, and less mental health. Parliament and county assemblies, the laws that they enact, will that help our young people, empower them so that we are having less issues? On religious organization, are we providing moral support? Are we providing periodic guidance and counseling? Do we talk and listen to the children? And remember, healthcare for these young adults and adolescents need support for both the young adult as well as their support system, the parents. Are we counseling them too? For local communities and school, our nutrition programs, our family programs, our school programs, are we covering family life, guidance and counseling? Are we addressing emerging lifestyle issues? Are we coming up with solutions to mitigate the issues that we're dealing with? So for Ministry of Health, I think really we should establish holistic care amongst this group. And I will repeat again, there is a big gap on mental health globally, not just only in Kenya or in the counties. And also we should also include like the business communities. The economic wellness definitely contributes to good health, and also innovative solutions to deal with this special group. If these 30% are not well, whole, as in holistic health, we will not get their maximum functionality if they don't get the support that they need. So the next slide, please. On outcomes and interventions, really.
3 more minutes, please. 3 minutes.
I think adolescent health should be accessible, affordable, and quality so that we can reduce the mortalities, the impacts, and we should be ready to handle chronic illnesses that will be coming up in this group. We should think globally with the next slide, please. With the introduction, especially like with the fast foods, I know we've been dealing with stunting and malnutrition, but in the future in this group, coming up with the fast foods, we'll also be dealing with other chronic illnesses like heart disease and obesity. So really the care should be holistic, family-centered, patient-centered. And for preventative services, we need to ensure we have all services available. Next slide, please. On sexual health services, I think screening and counseling, birth control, and STI treatment and management should be increased in the home, in the schools, in the health facilities, even in the community outreaches. Next slide, please. I think I've covered the importance of mental illness affecting holistic care. And in summary, next slide, please. Allow me to say that SDG goal number 3, advocates for good health and wellness. So we need to reduce the risky behavior and health conditions. We need to have rich data that will go a long way in evidence-based investment, preventive guidelines, and have a multi-sectoral approach. Healthcare policies and NHIF Act should also focus a lot more on adolescent young adults, and government should spend more funding on this age group. The next slide, please. Next slide, please. What is a comprehensive adolescent health package? For the comprehensive adolescent health package, it needs a multi-sectoral approach. We need to ensure that we improve the access to nutrition and healthy foods, promote physical activity, improve healthcare seeking behaviors, promote safe environment, reduce and minimize harm from substance abuse, promote sexual and reproductive health, and promote mental health and well-being. We can only do this if we can provide the funding, get the right human resource, have the service delivery that is youth-friendly, use technology to give information to this age group, get the right quality data to have impactful programs, and ensure that we all have in our counties, in our CIDPs, in our annual work plans, in our programs, we need to focus to this special group of population. Thank you so much.
Thank you very much, Honorable CEC Ruth. That was a very comprehensive presentation, and really highlighting that the issue of financing of a multi-sectoral approach for young people, for adolescents and young people, is so critical. And you really did talk about how because the adolescents are about 35% of the population in Nandi County, how it becomes critical to look at this group comprehensively with the sub-county context in mind, and also the differences that arise because of rural-urban. Definitely the focus on prevention, you've really highlighted that. And one can see the complexity of issues that are affecting adolescents and youth, and yet, as you correctly say, the focus on prevention can really deal with that. And of course, you've highlighted mental health, something that is a global concern and now increasingly has become our own local concern. So thank you very much. I continue to invite participants to put their comments in the chat so that we will have time to go over those, even as we have a Q&A at the end. Now it's my pleasure to invite Dr. Ruth Laibon Masha, the CEC of NAC, to give us her presentation. And so Ken, if you'd kindly upload that presentation and please put it straight away into full slide mode. So welcome, Dr. Ruth.
Thank you very much, Sheila. I don't know how well my internet is to manage video, so I'll stop the video. Allow me to start. Is the presentation out?
Ken, you're loading. Where is Ken? Ken, please load the presentation.
Are you able to see?
Okay, maybe I can share my screen.
Are you able to see it?
Yes,
Yes,
I can
we
hear
can
you.
we can see. Thank you.
Sheila, there's quite some noise on the background. I don't know which side.
Yes. Erastus, Erastus, would you mute, please? Would all participants please mute so that we don't get the echo? All right, welcome, Dr.
Okay, thank you very much. My presentation today centers around HIV/AIDS, morbidity and mortality among adolescents and young people. We've heard from the previous speakers that HIV remains a key challenge for this subpopulation. And I will just briefly go through some of the key issues. Next slide, please. I would like us to say that not only in Kenya, even globally, that we are seeing that especially the cohort of young people, mostly with the data, as you had the challenges that we have of data, usually we capture more of the 15 to 24. We have more new infections among young women than young men. But the challenge is actually that although we've been seeing good progress, the decline is not fast enough, even at the global level. Next slide, please. At Sub-Saharan Africa, we know is home to the 88% of all adolescents living with HIV between the ages of 10 to 19. And the challenge is that even when they're infected, we still continue having more deaths as compared to adults living with HIV. So these cohorts then present a challenge of management when they have other AIDS-related comorbidities or diseases. Next, please. Now, in Kenya, what does this mean for us? There is implications of having high HIV burden among adolescents and young people in the context of a youth bulge population. If you look at how our population structure looks like, if you look at the ages 10 to 14, 15 to 19, 20 to 24, we're having a couple of transitions within the HIV epidemic. One transition is that a large cohort of people who got HIV in the yesteryears are moving towards what we call older people living with HIV. This generation then begins to have other comorbidities that are related to HIV, including diabetes, blood pressure, the cancers, and also related to old age. On the other transition, like Ruth from Nandi just told us, is when we begin to have another cohort we are growing living with HIV. So what does that mean? It means that our goal of ending HIV by 2030 is really going to be impacted by the fact that we are not eliminating HIV, especially among children below the age of 14. And then we are also having adolescents acquiring HIV between the ages of 10 to 19. In fact, for Kenya, if you look at HIV incidence, we have big challenges from the ages of 10 to around the ages of 29. So for the young adolescents, you find that one of 3 of every new adult infection is among young people. And in the modeling estimates we are having, if we don't do anything, or if we continue doing what we are doing today, we'll find that we'll get big at around 183,000 annual new infections among this subpopulation by 2030. So what does that mean for us? It means that if we are currently doing a cost of around 6,300 just for ARVs alone, somebody getting infected at the age of 15, multiply that by the average life expectancy of around 67, and you can see what that means in terms of sustaining that particular cohort on HIV. Of course, we've heard from what previous speakers have talked about: psychosocial impact, economic loss, and health systems being overloaded by the fact that HIV is a chronic illness. Next slide. Now, in terms of morbidity, we also have issues, of course, both pediatrics, we count the 14-year-olds as pediatric. We have issues around regimens that are quite effective. We also have issues around poor adherence, especially adolescents when they go to school. There's stigma and discrimination. You find that most of them also have questions that those that have not been able to get enough psychosocial support, therefore taking medication on their own become a challenge. And then we also need to note that even when you look at our data, if you look at viral load suppression, you find that the adolescent and young people usually still continue having lower viral load suppression than adults. And this then becomes a big challenge. Next slide. Around mortality issues, while we had around 64% reduction of total AIDS-related deaths from 2013 to 2019, you'll find that on the cohort of adolescents aged 10 to 19, there was only a 19% reduction. And that's why the previous speaker did indicate that the previous speaker did indicate that death, HIV related causes among the highest causes of death are for adolescents, especially for that age of 10 to 19. Next, please. The other element I think we can all attest to is teenage pregnancies. Now, teenage pregnancy on our side in HIV is a proxy indicator of heightened risk to HIV infections among girls. If you look at the map there, you see that when you try to overlay data on teenage pregnancies, which may not be as accurate, but basically from the DHIS, and then you see where the bubbles are becoming bigger, you'll find that also HIV incidence around those areas is high. What does that mean? It means that we get a cohort of adolescent girls whose sexual debut is within a high-risk geographical location. That means that if the first sexual intercourse is unprotected or is as a result of violence or is not protected or having any protection such as a medication such as PrEP, you'll find that these adolescents become at a very high risk of getting HIV. And therefore, we must look at teenage pregnancy as a proxy indicator to HIV and address it with the seriousness and the urgency it deserves. Next. We also have compounded factors, mostly structural. Ruth did allude to some of them, so I'll just talk about, of course, what you said is also suboptimal uptake and coverage of available services. We have issues of policies. I know earlier we talked about policies, but I want us to look and reflect and have a meeting with ourselves and ask ourselves, how do these policies affect the adolescent girls and young women? What agency do these girls have, especially when they become sexually active? We need to look at policies in the context of an agency of especially young girls that lies with a society that is also judgmental from the health facilities, from parents themselves, from the faith communities. And these adolescents, even when they have the agency to tell us what they need, then we still have issues around a policy and society environment that then ensures that they are not able to have the optimal uptake of services. I went to Lesotho and I was so surprised to find that sexually active adolescents who have either had children would come early in the morning in their school uniform to pick their contraception. That is a policy that has allowed them to do that. But for us, I know we have issues. The minute we talk about a policy, then we begin to have the politicization of adolescent sexuality. So that is an issue that is really compounding their health. And it's an issue as a country we must deal with because we cannot hide the challenge with the palm of our hands. The other element, of course, is for those living with HIV is lack of disclosure and stigma and discrimination. We find that a lot of them only are told that probably, especially those who are perennially infected, they only get to know that they have HIV way late in their lives. And then some of the medication they take, they are told maybe they are for heart disease. And then they discover, they get disoriented, and then you get the fact that we lose a lot of them because of non-adherence to the medication. Of course, we have other factors such as the lack of comprehensive knowledge for those who are getting sexually active, and as well as socioeconomic vulnerabilities and lack of autonomy and agency, especially in the context of poverty. So what can we do better? I think one element that we must do better is first, the political leadership, and next slide, please. Political leadership and prevention and commitment to prevention, especially for HIV among these young people. We currently have nice policies, but we lack proper investments that can be used to address this cohort at the scale that is intended to manage HIV or to prevent new infection. Then we also have reluctance to address sensitive issues. We have things around currently within the program. We are aware that majority, we are getting a large cohort of young people becoming men who have sex with men. We have them, but we may not admit, but they are young people. The policies does not allow us to directly target them. But when you go to the site in the program, you find young men, young as even 15, 16, 17, and they tell you, I am gay, I'm having sex with men. And yet we have policies that we are not able to reach out to them, because if we don't provide that service and ensure that if we can't change the direction they have taken, that we can be able to stop the infection, then we'll have a challenge. Another cohort that is emerging is what we call sexual exploitation, but this cohort of young female sex workers, while we can be able to address it from the fact that we talk about sexual exploitation and the law is very clear on that, then you find in programming, you will find these young girls again on the streets, and they also need services. So the issue is, how do we then have policies that are sensitive to these issues? Because you may not round up all these girls immediately from the street, but they're there, they're in the sex dens, and they're selling sex. I think another thing we can do better is that we lack a business style approach to the prevention management and service deliveries. Currently, we fund outputs. So people, we give money, we say you train people, and this is the output. We need to begin having a business style model where we are saying, can we find outcomes and impact level indicators so that the money can actually have value among these adolescents. I know we speak a lot about, let's have youth-friendly services, let's have this, what the young people want us to do, but engaging those young people has to be systematic. Usually the cohort does not stay there for a long time, they graduate, and the risk is heightened because of that adolescent period. And if you can be able to be systematic and ensure that you're delivering programs at scale in a business style model that recognizes our inputs as well as our outcomes and impact, then we may be able to change that scenario. Next slide, please. So again, we heard about the solutions. One of the solutions I think that I would want to talk about is that we have so many activities that we talk about adolescent. On one hand, we have different agencies doing something, but the coordination remained very weak, especially on interventions that are aimed towards social protection. I want to say something like an intervention of sanitary towels. I think it's important for us to realize that a lot of girls' vulnerability starts usually during the start of MENAC, because at that point is when they are not even free, sometimes depending on which family background they come from. If they have not been exposed to discussing issues of sexuality, they have not been told about menstruation, so they shy away from talking about menstruation. And some of them become so vulnerable at that age. And if we can be able to identify these girls at the start of MENAC and ensure that they are given sanitary towels, with time, these girls are able to graduate and they're able to actually even seek help even from their parents. And therefore you are able to reduce that short window of vulnerabilities that would have happened. If you look at the girls' transition and HIV data, you overlay transition between class 8 and form 1, and you also look at after form 4, when they are not sure where they're going to either going to university or college, you start beginning to see some peak. So we need to manage transition. We know that education is indeed a protective factor of HIV. So we need to begin asking ourselves, especially for girls, what can we do during that transition period? What interventions can we have within that December to whatever time that the children are going back to school, especially targeting the girls within the community setup? Of course, we've been talking about integration for a long time. And I think for me, I would like to say this is about choices. What choices do the girls who are sexually active have? We also have to remember that we've been talking about friendly services, but we also need to have a youth-led movement and can provide a platform for us to provide multiple choices for these young people. We need to look at
2 more minutes. 2 minutes.
Yes, and I'm just finishing. And then the other part is that I think we need to look at the male partners. As I said earlier, the geographical location where these girls are coming, in addition to keeping them in school. While you're programming for the girls, we also need to ensure that we have their male partners covered, especially in high burden areas. Of course, the data issue was spoken about. Also, the other element that I want to mention is that not all adolescents are the same, and therefore we need a tailored approach. If you look at vulnerability across the country, you find that some of the, especially social cultural issues, are not uniform, and therefore we need to look at what packages are out there and how we can program with the context of those young people. I've just spoken about that education, but in a nutshell, what I would say is that we've done a lot, but we can do a lot by bringing our collective efforts together, making sure that we are being able to measure impact and ensuring the interventions are being implemented systematically and to the scale that is desired to end HIV among adolescent and young people. Thank you.
Dr. Ruth, thank you very much for a very comprehensive presentation. And one of the things that you highlight very effectively is the reality that we are seeing a third of new HIV infections in this age group, that we must remember that when they transition, they then get other comorbidities that we had not thought about. And then something that is echoed by you and also by Honorable CC Ruth, and also by Dr. Christine, that we cannot hide about the issues of young people anymore under the rubric of culture, or what is it? You know, we are adults who are blocking young people from getting services and information because of our own ideas, you know, our own hesitancy. And we really cannot afford to do this if we're to help young people. Then the reality again of multi-sectoral programming that is needed, and of course then financing outcomes. A lot has been done, as you said, but if we had more robust data and we were more nuanced in the way that we're doing things, there's an opportunity. Now, having listened to these excellent speakers, we are now coming to the time when we will have some discussion. We do have a bit of time, and what I'm going to do actually is to start with the comments that were in the chat, because those are the people who first put in their questions or comments, and then we will have a response either from Honorable CC Ruth or Dr. Christine or Dr. Ruth. So the first is a very specific one to the Honorable CC. I'll read it. And it asks, are there any deaths in Nandi related to teen pregnancy complications? And what are the strategies that the county has put in place to handle adolescent mortality? Has Nandi put any budget for this concern? So Honorable CC, if you could respond to that, please.
Thank you so much. In regards to teenage pregnancies, definitely we know like one of the issues that we are having is low hemoglobin levels, nutritional issues, of which we have started a program where we are giving supplemental IFAs, especially among the teenagers, and also during prenatal care among this group. But remember that the same group, because they are shy or they are hiding their pregnancy, they don't get the prenatal care that they need. But we have been advocating for antenatal care, which they usually say 4, but we've been saying 6 to 10, so that the more they are seen in the clinics, then we can give them the supplements. And for the teenage, you're talking about deaths during when they have the babies. They are definitely high risk if they are already low in iron and they have blood loss and their body is not ready to have a baby. Definitely that would be a problem, but no, we do not have like a high significant, but even losing one teenager would definitely impact a family and it's not okay. But I would say on issues to do with botched abortions, self-inflicted abortions, they are there.
Okay, thank you very much, Honorable CC. The next question I will ask Dr. Ruth, Masha, please to address. And this comes from Lillian Kayaro, and she echoes what you said about needing to package health comprehensively. But she says we shouldn't look at it as just a medical issue. That and therefore that means not just looking at health facility data, which is what we tend to do. She says you should look at other sectors like social protection or youth sectors, which are offering us services. So maybe you can comment about that, the comprehensive outlook that's not limited to clinical services.
Yeah, thank you very much, Sheila. Indeed, that is very right. We look at the factors that intersect for the vulnerabilities of adolescent girls. They are way outside mostly one sector. The health sector actually becomes the place where we meet these girls, as alluded to, either pregnant or they have a sexually transmitted infection. So we look at other sectors actually as the sectors that could, whose strength can be harnessed to be that preventive approach that we need to put for these girls. So I think the only challenge we have is that we have currently not suboptimally or optimally brought in all the sectors together to be able to see how are we doing in a certain geographical location. So an example is, I recently was called to Homa Bay and in a small village, and somebody said, you know, in my village, there are around 200 girls who are either pregnant and some have seroconverted to HIV or others have just given birth. And I said 200 in the same village. And I arrived in Homa Bay and I requested to see the girls. I met around 40 of them. Some have just given birth 3 days earlier also, and those who have just been diagnosed with HIV. And I looked at that context and I saw that there are quite a number of sectors that are involved. There are a number of defilement cases. So we have the children's department. There's a number of a number of other elements within that, you know, the social protection elements. There's also the fact that also the school that these girls are going to, although we are taking them back when they've given birth, could also be an element where we can see how do we intervene so that the other girls don't join in. So I do agree, but I also say that we need to coordinate ourselves better, especially from the perspective that although this is a health issue that ultimately shows itself as a health issue, it starts from a different set of other interrelated sectors that are within other departments. So my take is, as government and what we are looking forward to do, even as a council, we, especially as far as HIV vulnerabilities are concerned, we want to put a very strong multi-sector and multi-sector actions jointly together to be able to address this issue. Thank you.
Thank you very much, Dr. Ruth. The next question I want to, I think it seems to be addressed to Dr. Christine, and it came from a comment raised by Janet. And so, Christine, the question is, there's been a lot of comment about data. You yourself have talked about it. And given that in this conference, we know that following after this is going to be a population policy, and what is critical is data. Are there any efforts at the national level, given that you head the Division of Adolescent and Sexual Health, to perhaps work with the HIS division to change this situation for adolescent data? Maybe you can speak to us about that.
Okay, thank you so much for that question. Yes, there are efforts that have been made towards this disaggregation of data. So we have been talking with HIS and we are trying to approach it from 2 ways. The first way is to request that programs that are dealing with adolescents to actually have that disaggregation within their programs. Very successfully, we have seen HIV program and the sexual reproductive health program disaggregating their data. So we're able to see this very clearly on HIS. So the other option that we're looking at is having a scenario like the child welfare clinic, but for adolescents. People have usually called it a youth-friendly clinic, but that brings a lot of connotations of, you know, video games and all that, which we are trying to move away from. And we are like, we want to provide, you know, like holistic service with competent healthcare workers and a very articulate data system within that. So the same way the CWC collects data for under 5s, we want all adolescents in the facility to be seen at that youth clinic or the adolescent clinic. We have a special register that is now fed into DHIS. So there have already been talks on that. There's a draft register that has been made under the leadership of the Division of Reproductive Health, but with consolidations from other like non-communicable diseases and from our division as well. We've also contributed to that. And it is currently in pilot phase. So it has to be piloted and to see how this data can be seamlessly uploaded on the HIS. Another thing we're doing as a division is the adolescent health study, the survey that I mentioned. So we are the same way we, the DHIS that is done routinely every 5 years is not really geared or powered for adolescent population. It's for the general population. And then you get a lot of these figures of 15 to 49 where you're not able really to see what the adolescent has. So this adolescent study is actually powered to get data from the 10 to 14 and 15 to 19. And we've done the first one. We're about to release the report. So it's cutting across all issues, HIV, reproductive health, mental health issues. And we've actually done an analysis of these adverse childhood experiences and against the issues that they bring out in childhood. So like if you have like a parent who's incarcerated as an adverse childhood experience, how likely are you to suffer from depression or suicide or anxiety or things like that? So that analysis is part of that study. Among other analysis, we also analyze the health system, and the data that we're going to get from there will also show us how to improve the health system. So we're looking forward to publishing this report, I think within the month. And we also want to give a special recognition to the National AIDS Control Council. We have worked with them together from the inception of this up till the data collection, and now we are completing the analysis. So thank you, Ruth, Masha, and team for also helping our division on that. Thank you.
All right, thank you very much. Now I'd like to open this session up now in case anybody would like to ask a question. Kindly unmute and ask your question. This is the time for you to do that. I note that we do have 1 or 2 comments in the chat, but I want to give an opportunity. So anyone who would like to unmute, please, and ask a question, now is the time.
Hi, Dr. Sheila.
Yes, please go ahead.
Yes, like Dr. Christine, my name is Lillian Esemere. How can we be enjoined in some of these noble events which are going on so that we can be parties or allies to the whole process and maybe see how we can contribute, particularly for some of us who are not directly from the health sector, but now we represent these other sectors which are non-health?
Thank you, Lillian. We usually have an adolescent health technical working group. Participants from this technical working group come from, the Ministry of Education, the Ministry of Gender and Social Services, and the like. So we would be happy to have you on board. I think maybe I can just post my email, and then we can link up after this and have a discussion. I'll just post it on the chat. Thank you.
All right, thank you, Lillian. Anyone else? A comment, a question?
Dr. Sheila, this is Janet.
Please go ahead.
Yeah, I just wanted, I want to thank the presenters, and I was very surprised. I've been on adolescent programming for some time, and there are a lot of policies and a lot of guidelines. Now, I will ensure that the communities and people who work around adolescents are aware of these policies. And if the big documents cannot be disseminated, then we have popular versions or the ones that affect adolescents or the key highlights, so that at least it starts implementation. Look, we've been using school health policy from 2009 for a long time. It is only after 2018 is when we have another policy, and not very many people know about it. Is there a possibility that we can make this our priority? Thank you.
That's an excellent point, very excellent, because I also, as I looked at the presentation, realized, oh my goodness, we do have a lot of policy guidelines, and the real question is, are they getting to the point where they can be used? And and then across sectors also, because if we're saying a multi-sectoral approach, then we also need to know the guidance that's coming from other sectors. And some of them were presented here, but I don't think that it's comprehensive. So definitely a very good contribution. All right, The floor is still open for questions or comments.
Hello, Dr. Sheila.
Yes, welcome. Please introduce
My name
yourself.
is Doreen. My name is Doreen Wakio, and on the issue of HIV and sexual infections and all others, I would urge maybe if parents, because if you can check, and I've done some checks, you find that even school-going children, like the lower classes children, they have sex maybe with their brothers and their cousins without their consent or without their parents knowing. If we could start with the parents, we just try to let them check on their girls, how they are doing when they wake up in the morning, how they go to bed, because you know the reality of the parents is just go to bed and that's all. So we find that they learn from home. Now before they go out, they know everything and they want to reach to more activities, they want to know more. So if parents could be guided and or could be maybe have a civic education on how to teach their children on sex, how how girls change, boys change, maybe that could even reduce even with the pregnancies, the infections, because most of the children, they get it from home, from their brothers, their father, their cousins, and then now the trend goes on. Yes, thank you very much.
Thank you very much, Doreen. You really bring up a very important point about the role of parenting. And we noted earlier that there is even guidance on positive parenting, but that needs to be disseminated so that people can act on that. It needs to be a real part of our program. Thank you very much. I want to end this session with a question that was posted by Farida Salim. And I think this is perhaps will be answered by Honorable CEC Ruth. We have a short time, but I think we can swing it. About county budgeting for adolescent programs. Mostly it's NGOs and well-wishers who are supportive of adolescent programs. In Nandi County, are there any efforts to change this situation? Honorable CEC.
Thank you so much. Yes, I did notice on the issues to do with budgets and the NGOs. Allow me to thank the NGOs because really they were among the first ones who took it upon themselves to do programs that were tailored to every age category, especially if you look at it in the HIV AIDS programs or the TB programs. And what I mentioned really on the budgeting issue is across the counties, our focus has mainly been on maternal child health issues, or if you look at the new thing, non-communicable diseases, cancer, and whatever, we have not put sufficient money to these population group. I will repeat it again, that the adolescents and young people are being treated and being mixed with the adults. I don't know how many counties specifically, other than the private facilities, that have specific areas and more specific focus on this age group. I think we need to put a line item. The only time we put a line item, the way we put in nutrition as a line item in our budget, that is where you will see a difference. And we also need to make sure that their healthcare, first of all, is very unique. We need to give them different platforms, whether it is online, like we have a hotline in Nandi County where they can call and be directed and they can talk to anybody. I would encourage all counties, have a suicide hotline, because suicide is on the high, especially among these age groups. So having a digital platform where they can also access information and even making their healthcare access be very unique. It doesn't have to be in a hospital setting. You can put it in the middle of town. You can put it like we have a health complex, and I have asked, a sports complex, and I have asked for a facility, a space to set up a youth-friendly, a young adults clinic where you're not mixing them up with everybody. Because really what their biggest fear is being judged.
Okay, I think we seem to have lost Honorable CEC. However, we've come to the
and
end of our...
Yes, thank you.
All right. Sorry, Cece, we lost you a bit. We've come to the end of our session. Thank you, Honorable CC. Ruth, thank you very much. Dr. Ruth herself from NAC, and thank you, Dr. Christine, and the participants. Big takeaways today. The issues of adolescents and youth are comprehensive, they're multi-sectoral. They definitely need us to put resources there. Programs are not just in the facilities, they must be also outside. The issue of data and how we can collect more accurate data about young people, and recognizing that young people will transition to adults, and some new things have come up for us now with mental health, the issues of menstrual hygiene, the issues of homes that are not safe. So definitely a lot to do, a lot of opportunities and a lot for counties to think about. So thank you very much. I would now say that we've come to the end of our session. And as we were told, we will have a break of 10 minutes, and then you then can go back and join the next session. Ken Luaki has put that he's encouraging participants to join the next session on the causes of adult illnesses and death. But for now, I'll say thank you very much. God bless you and enjoy the rest of the day.
Thank you. Thank you, Chair. Thank you. I think you don't need to leave. You'll be taken back to plenary. And
All
then
right.
you have to, please don't leave.
All right. So you're going to move us to plenary. That's fine then.
Yes, because it is virtual, so you will not move physically. So we're going to move you
right.
to the plenary, and then you'll have to rejoin back.
All right.
Unless
Thank
there's
you.
anything. Please remain.
Thank you very much. Thank you, Ken.